Hello and welcome to Post-Exertional Mayonnaise podcast, a podcast about living with ME and chronic illness, creativity and making meaning. I'm really honoured today to be joined by Dr Nigel Speight. He's a semi-retired British doctor based in the northeast of England, and he specialises in paediatric ME, CFS. He's been involved in fighting many child protection cases in which children with ME were at risk of being removed from their parents. And in the past, he's acted as a voluntary paediatric medical advisor for many ME charities. So it's really good to have you here. And it must be about 30 years since we've seen each other, because you were actually my childhood paediatrician. So it's been a while, but it's so good to talk to you. So thanks for joining us.
Pleasure. Thanks for inviting me. It's nice to see you again.
Yeah. It's life.
You were one of my first cases, and you experienced the same sort of disbelief on the part of other doctors that many families suffer from.
Yeah, and it's interesting because I was talking to my mum recently about sort of like the timeline of when you became involved in my health, and she says hello, by the way. But it was interesting because I went through a period where there was a child psychiatrist who was involved in my case, and I had a short period of inpatient care at a hospital, and my parents decided that they were going to discharge me because he was getting me to exercise and things like that. And I think it was not long after that you became involved, and we found you, and you sort of made such a difference in our lives in terms of kind of just the illness being seen and validated, really, for me as I was sort of 11, 12 at the time. So so thank you for your involvement, really.
If I remember rightly, I think your case illustrated another feature, which is that looking at someone with ME, you shouldn't accept all the problems as due to the ME. And I think I detected that you were also suffering from migraine. Helped you with diet, maybe excluding chocolate and cheese.
Yes.
And you were improved so much that the rumour went round that I had a cure for ME.
Oh, really? I don't know. Yeah, I did.
I assure you. Yeah.
Yeah, you've got a very good memory. Yeah, I remember there was migraines, and I haven't had. Interestingly, now as an adult, I haven't had the migraines.
Yeah.
But I do get tremors, and one doctor wondered whether the tremors were kind of like migraine, but not. I don't get the headaches as such. But
I do find that migraine is a very common concomitant with ME, and it's always worth looking for.
It's interesting. Yeah. But I hated cheese and orange juice and chocolate. They were some of my favourite things. And we cut them out. So that was whether that did have an impact, I don't know. Or I seem to go through phases as a young person with ME that I kind of went through.
I can assure you, it had a major impact.
Maybe I should. I should try it again then. Yeah, interesting. So, do you want to tell us a bit about kind of how you became interested in ME as a condition? Was it a challenge sort of stepping out and providing clinic places for children and young people with ME? Was that, how did you kind of...
It's because of a book I'm trying to write on it, and there are 3 factors that affected me very early on. I became a consultant way back in '82. I'd never been taught anything about it in my entire paediatric and medical career. I'd vaguely heard about it. And one of the first things was I read an article by Dr. Charles Shepherd in World Medicine, where he described his situation, where he could just about limp around the house and open a can of baked beans occasionally, but that if he actually took his Labrador Retriever for a 100-yard walk, he would then be bedridden for a week. And that just struck me as rather genuine and impressive. Then at the consultant's dining table in Durham, I was sitting next to an otherwise excellent physician, who's probably excellent in every other field, but she opined to the other members of the table that all her ME patients were nutters. And I didn't disagree with her, I just noted it and remembered it. And the next crucial thing that happened was that a 14-year-old girl turned up in my clinic in a wheelchair and announced that she had ME. and described it. So I said, tell me all about it. And she told her story, and it was so vivid and real. She said how she could just about manage 3 half-days of school a week, and that she used the wheelchair just to get around, and that if she did more than that, she'd be bedridden for a week. And her parents were members of the local charity, which they invited me to go to. And finally, a very fine lady GP called Rosemary Woods invited the late Betty, her name, Betty Dowsett, to give a lecture for an evening meeting. And this was absolutely brilliant and formative. She described all the clinical features of ME, all that was known about it, and some of the theories of causation with the post-viral etiology. And once I'd heard that, that empowered me to make confident clinical diagnoses of ME, just because she taught me. And it's interesting, whenever I've given lectures, the next week a doctor will ring me up and say, oh, I've just seen a case. Now, and you just have to kind of recognize the pattern. So those were all the things that got me going. I then went on. I was aware of the psychiatric view of ME, and I just did the kind of little boy saying, has the emperor got any clothes on? And wrote to all the paediatricians in the northern region with a questionnaire. I simply asked them in this questionnaire, I just wanted to know what their belief system was. So, because I was getting patients coming from all over the northeast, and I wanted to know which ones I could successfully kind of divert back to their local paediatricians. And the questionnaire had 3 boxes to tick, to choose from. Either you believe that ME is primarily a medical illness, or you believe it's primarily a psychological illness, or you don't know. And I was quite heartened. In those days, we had quite wise, old-fashioned, broad-shouldered paediatricians who took decent histories, and 19 ticked the organic box, and 7 ticked the psychological box, and a lot of the super specialists just said they didn't know. I was emboldened by this and supported by it, but I then sent the same questionnaire to all the child psychiatrists in the northern region. And it was quite an interesting response. None of them ticked any boxes, and instead ticked me off, said I had no right to ask these questions, and hadn't I heard of the mind-body continuum. So that was an interesting response. And I then ploughed on. Obviously, the word got around, so patients were coming to me just for diagnosis from all over the northern region, and that's how it all started.
So was there often then a lot of tension between what you were trying to do and your kind of like your view of the illness and then the sort of psychiatric kind of departments? Because for me, it was like there was very much that tension of, and I'm sure you probably, I mean, I don't remember, but I'm sure you were probably involved in my case, in supporting myself and my parents in terms of like education or you know, there was I was labelled as like a school refuser, for example, because for whatever reason I didn't want to go to school, which wasn't the truth, and it wasn't kind of like it wasn't my perspective of school. When I was able to go to school, I really enjoyed it, and it was I wished I was able to be there, but I knew my body couldn't kind of cope with it a lot of the time. So that was on my record as being a school refuser. And was there a lot of tension there in terms of like yourself and having to sort of fight battles really with the sort of psychiatric side of things?
Not just the psychiatrists, the paediatricians who didn't believe in it and who wanted to, for some reason, some paediatricians regard it as their duty to get children back to school and to prescribe how much school they should go to. So the first tension was with paediatricians, but and you know, innocently, I still assumed that until proved otherwise, everyone would naturally believe in ME, because in childhood it is so easy to believe in when you see someone who's been bright-eyed and bushy-tailed and going to Cub Scouts and Taekwondo and swimming club, who's suddenly struck down by an illness out of the blue, that's primarily a medical illness. Interestingly, I once had a discussion with an adult neurologist. And as you know, adult neurologists haven't wanted to be saddled with ME despite the World Health telling them it's a neurological illness. And we got chatting, and I said I had an interest in paediatric ME. He said, "Oh, does it occur in children?" And I said, "Oh, definitely." And I described the picture of the bright-eyed, bushy-tailed child. He said, "Oh, maybe I should think again." In other words, the picture is so clear in childhood that it should help to disabuse the people who believe it's all psychological.
So I think you'd be a good person to ask in terms of, it's not something I've sort of we've covered on the podcast until now. We've been doing this about a year, but would you like to tell us a bit about the history of ME as a condition and how it's become psychologized? How did it end up in that kind of like remit of psychology kind of taking hold of it, really?
Well, it's an old story, but it all stems from the epidemic of ME in North London in 1956, which specifically, in particular, affected the staff at the Royal Free Hospital, so much so that it was called Royal Free disease. The Melvin Ramsey, who was the physician at the Royal Free Hospital, wrote it all up, described the clinical features beautifully, and it was accepted from 1956 to 1972 as an organic illness. World Health defined it in 1959, and either the BMJ or the Lancet invented the term myalgic encephalomyelitis. So this was an epidemic of viral meningoencephalitis, which left a lot of people with the sequelae of ME. Everything might have been all right, although people still weren't taught much about it, until two psychiatrists in need of a PhD thesis called McKevedy and Beard from the Middlesex Hospital asked to just have access to the notes of some of the patients. As you mentioned, the Royal Free was so severely affected, I think it actually had to shut down as a hospital for 6 months. Wow. So many of the staff were off. And these two psychiatrists studied the notes and said there were no positive tests, and that their physical signs were lacking, and that they had some symptoms that couldn't be explained, and came up with the monstrous idea that it was all mass hysteria. And they got published. Dr. Ramsey wrote a dignified refutation of it. The psychiatrists have been careful not to see any patients at all. And their main argument, apart from the slightly atypical version of some of the clinical features, their main argument that it was mass hysteria was that it was mainly women. And the reason it was mainly women was the Royal Free discriminated in favour of women as medical students. So about 90% of the students were female, 90% of the doctors were female, and 99% of the nurses were female. And they were struck down by this epidemic. Now, that gave the psychiatrists a foothold in the field. What happened subsequently in the next 50 years has been a kind of tug of war, up and down. Sometimes we're winning, sometimes they make an advance. But the thing that's always puzzled me is why basically the organic medical profession, adult neurologists, adult physicians, to a lesser extent paediatricians, abdicated their responsibility for ME, allowed the psychiatrists to make all the noise, and all the research was done by psychiatrists. They built entire research empires on it. And the psychiatric theory, called the biopsychosocial theory, is that it's not really a disease. It might be an illness with a virus for the first 3 to 6 months, but thereafter it's perpetuated by faulty illness beliefs, and that the patients are told by the charities to rest in bed and they get deconditioned. And if this theory was correct, ME wouldn't exist, because everyone would have been cured of their faulty illness beliefs by cognitive behavioral therapy, and then they would have reconditioned themselves with graded exercise therapy. And that's what the empire was built on, the massive psychiatric publications on the PACE trial of 2011. And this suited the government, of course, because it meant you didn't have to pay so many benefits if it wasn't really a disease. And I set up debates with paediatricians on this and had meetings with child psychiatrists on it. And time after time, we thought we'd won. The chief medical officer's report in 2002 came down firmly on this being a medical illness, but they fatally recommended graded exercise and cognitive behavioral therapy, which of course supports the other theory. So it's been up and down. If we want to jump to the present time, currently we're winning. The NICE guidelines and the National Institute of Clinical Excellence have finally debunked all the research on graded exercise and cognitive behavioral therapy as very poor quality and faulty, and they have withdrawn their previous recommendation for it and have stated firmly that this is a medical condition affecting multiple symptoms. And that came out in 2021. And the psychiatrists are squealing and writing refutations, claiming they were right all the time, but they're basically facing the fact that they have wasted the last 40 years of their lives chasing a will-o'-the-wisp. They, of course, are recovering by moving into long COVID, where they're going to do all the same things. But basically, NICE have hammered the last nail into the coffin of the biopsychosocial theory. We feel we've won, but who knows? So I've summarized 50 years of history.
Yeah, thanks for that. It's
Does that make sense?
Yeah, it's helpful, and I think and I've mentioned it a few times on the podcast before, but like I sort of recovered. I don't know what the word would be in my late teens, and sort of that was kind of back in the late 90s. And then obviously hit by ME again 20 years later. So it was obviously sort of lying there under the surface somehow.
Yeah.
But what I hadn't really kept in touch with, I mean, I'd kept in touch with one or two friends from my ME days, but I hadn't kind of like sort of kept on top of the landscape of ME in that sense. And I think when I came back to it, and then I learned, this was sort of like 2018 when I became ill again, and I learned about the PACE trial, sort of reading into ME again, and I was kind of like really shocked because I was kind of thinking things should have moved on by that point. Things should have kind of like sort of developed, and research should have happened and things like that. And it was kind of like quite shocking to me to find that, and probably quite traumatic, really, I suppose, as somebody who then had become ill again and realizing that nothing had really changed, and actually, if anything, because of the PACE trial, things had kind of like gone backwards in a way in terms of the acceptance and of the acknowledgement of ME within the sort of medical field, really. And that was quite difficult to kind of like get my head around, really. It was
Well, it's all a case of the psychiatrist filling the vacuum left by the medical profession. And Carol Monaghan, the chair of the Parliamentary Special Interest Group, the MP from Glasgow, has called it one of the biggest medical scandals of the 20th century, as has George Monbiot in last week's Guardian, a brilliant article, which has caused a major impact.
Yeah. Do you feel that those psychiatrists and those people that have pushed this narrative and that were involved in the PACE trial, do you think they genuinely believed their position on ME, or do you think there was sort of like slightly dodging motives? I don't know what your view would be.
I'm afraid I cannot work out what their belief system is.
Right.
It is possible that their main motivation was academic ambition or something. I do remember a psychiatrist telling one of his patients, "You've got to get better with our treatment. Our careers depend upon it." And then when she got worse with graded exercise, they discharged her, and she was a bad patient. It was her fault.
And I think that's.
I'll tell you a story about. I've met some good child psychiatrists who believe in it, who are quite happy to see patients and check there are any additional problems. And one child psychiatrist told me the paediatricians kept sending all their ME patients to him, and he returned them all saying that they're psychologically normal who've got an illness. So there are child psychiatrists who believe it. I innocently sent, at her own request, a 12-year-old girl early in my career to our local child psychiatrist because the mother had said she had some additional anxiety and maybe that could help her. It is quite difficult having ME as a 12-year-old and trying to balance how much you go to school and this sort of thing. And I sent her along in all innocence. And when the mother came out of that consultation, she said she was so angry she had to wait for 15 minutes before she could trust herself to drive. And the psychiatrist had said to the little girl, right, I've heard that you've got a little friend called Emmy. Get it? And you've got to tell Emmy she's not coming round to tea anymore. And if she does, you're going to lock her in a cupboard under the stairs. And then he turned to the mother and said, now that I've dealt with that, if you'd like me to help you with your disordered mother-child relationship, I'd be delighted to. So that's a doctor squeezing a patient into a pattern he recognized from one that he doesn't recognize.
Wow.
The other biggest factor is there's been no decent education of undergraduates and postgraduates. In some ways, things have got worse from the old-style good clinicians who took decent histories. We're rearing a whole lot of doctors who depend on investigations, who've been through medical school and have never been taught about ME, or if they have, they've been taught by the psychiatrists. And the two major medical textbooks are both, the chapter on ME is still written by the psychiatrists. And of course, the term chronic fatigue syndrome was invented by the psychiatrists to weaken the strength of the term ME. And hopefully it is going to gradually stop being used. We're using the term ME much more now. Where was I was talking about psychiatrists and I've forgotten, I've lost my thread. Take me on another thread.
Yeah, no, it was and that's my brain thought, cognitive dysfunction for me as well. Where were we? Yeah, just talking about young people that weren't believed. Yeah, it's difficult, and it's interesting you mentioned about the parents as well, and the mum, a particular mum, sort of like, sort of becoming so angry, and you've done quite a bit of work with what was called sort of like Munchausen's by proxy, wasn't it? And
yeah.
I remember being involved in young people's charities, and I was kind of like on a national committee for a charity I think you were previously involved with as well. And I remember meeting a young person who'd there was like legal cases ongoing, and then there was conversations about young people that were being thrown in swimming pools and expected to. It's almost like a witch hunt, isn't it? It's sort of like, well, if you can get yourself out of this, you haven't got ME, and if you drown, you have, sort of thing. It's almost
You're absolutely right. It was the medieval test for witchcraft. Yeah.
But there was also this sort of pressure on parents then, the what became sort of fabricated or induced illness. Do you want to tell us, and that's kind of, you've done quite a bit of work around that and supporting families. Do you want to tell us a bit about your sort of work in that area?
Second, I've remembered my thread. I was talking about doctors who haven't been trained in.
Oh yes, that's right.
And a friend of mine in the southwest who has ME announced to her GP that she had ME, and he drew himself up to his full height and he said, "Madam, I've been a doctor for 12 years, and I can assure you that if there was such a condition as ME, I would have been bound to have heard of it." So it can't exist because I wasn't taught about it. And also from the southwest, a GP rang a helpline for advice, saying he was really worried that he might be getting ME. And they said, "Well, why is that such a big worry?" He said, "Oh, you don't understand. It's always been the policy in our practice to treat patients with ME with absolute derision, rejection, and hostility. And I daren't admit to my partners that I've now got it. So I'm going to take sick leave for depression because that's got less stigma." So there is a nasty, almost sadistic rejection and hostility to ME. Another friend of ours suggested to her GP that someone had thought she might have ME, and she said the GP's face went white. And, it's this fear of the unknown that we haven't been taught about. The facts of ME are actually very simple. I go around lecturing on it all the time. Coming back to Munchausen by proxy, at the early stages, I've seen real cases of Munchausen by proxy or fabricated and induced illness, and it is as rare as hen's teeth. I've probably seen 2 genuine cases in my entire career.
Wow.
And they're really peculiar, and they're, mothers putting blood in their children's urine to make it look as if they've got kidney disease and putting salt in the feeds to puzzle the doctors. And it's a weird condition. And the term fabricated and induced illness has been used to kind of supplant it, because the lawyers kept misusing the term. But I had to explain to some ME families sometimes that, it is real, and sometimes the doctors are right. But of course, a person with ME who's not been diagnosed, I often say that one of the best things you can do for a patient is give them an official diagnosis. And a diagnosis helps to protect them. Protects them from pressure from school to attend. It protects them from accusations of Munchausen fabricated illness. At the moment, I'm about to do a tour of Ireland, and people are flooding in with requests for me to see their children, because people have not got off the fence to make an official diagnosis. It's also happened with long COVID. Oh, I can't diagnose long COVID. I haven't been trained. So there is a really, I said we're winning on some areas. We're actually losing on another area, and this is the College of Paediatrics has adopted a wider definition of fabricated induced illness. The logic for this is questionable, but under the guidance of a child psychiatrist who has given workshops all over the country about it, everyone has now got a moral panic about fabricated and induced illness. The leap of logic that they've taken is to include under that umbrella of a condition that we agree is originally as rare as hen's teeth, patients with medically unexplained symptoms,
right,
and perplexing presentations. We have therefore, the umbrella now has 1,000 times as many potential clients. And I've seen A&E doctors referring patients straight to social services because the mother was treating her child with something that a private doctor had prescribed. But any patient with ME or long COVID ME, which is a growth area, who has not been given the protection of an official diagnosis, is a sitting duck for medically unexplained symptoms or perplexing presentations.
Wow.
And the flowchart that is taught by British Paediatrics goes down that you offer them rehabilitation from a multidisciplinary team for the condition that the doctor admits he doesn't understand. And if they decline that rehabilitation, usually by psychologists and people, the flowchart leads to a safeguarding referral. And at the moment, I've had a growth area of patients needing to be defended from these sort of proceedings.
Wow.
I've just helped 2 Norwegian paediatricians to defend a family in Norway where the social workers took both brothers into foster care for 4 years because the ex-husband's family said mother was making it all up. They had 4 years in foster care, and the social workers wouldn't listen to 2 professors of paediatrics in Norway because they were so sure that they were right. Finally, we got a happy ending just this last summer. Both boys are back with their family. And that was fabricated illness. So the great Osler used to say there are 3 principles in medicine: diagnosis, diagnosis, and diagnosis. And with ME, because we've got so little to do in the way of treatment, that's probably holds. Got to get off the fence and give a diagnosis. You can say it's probable, you can say it's possible, but at least give them a diagnosis. the number of medical letters that don't have a diagnosis in.
Yeah. I was just trying to dig out a letter, something that said what my diagnosis was this last week or two, actually, because I personally haven't seen a doctor or my GP for a couple, 2 or 3 years, because there's not a lot to talk about. But when you do need to sort of find something, you're sort of thinking, oh, what have I actually got that's actually got it written down anywhere? It's an interesting.
Probably mutated to chronic fatigue syndrome.
Yeah.
Again, a note of encouragement. NICE guidelines now call the condition ME-CFS rather than CFS-ME.
Yeah.
And I'm encouraging everyone to just keep using the word ME.
Yeah. And it was interesting because when I was diagnosed the second time as an adult, I was really clear that I wanted ME on there, because they were just going to write CFS, and I was like, no, I want you to write. And for me, that was like really important, because it was, and I think it was officially CFS stroke ME, but for me that meant a lot to me to have that on my diagnosis as an adult, because
you know the arguments for the stronger term ME. If you're a boy who's been off school for 2 years and you come back and your mates say, "Oh, why have you been off?" "Oh, I've had chronic fatigue syndrome." I say, pull the other one, you skiver. "No,
yeah.
I've had ME." "Oh, I've heard about that. It's quite nasty. Sorry."
Yeah,
and
interesting.
As one of the charity organisers says, abolishing the term ME, which the psychiatrists wanted us to do, and replacing it with the term chronic fatigue syndrome is as unhelpful to the patient community as it would be to abolish the term Alzheimer's disease and replace it with chronic forgetfulness syndrome. And we want forgetful.
Yeah, because it's so it's such a
strong labels.
Yeah.
If you've got asthma, it's easier to dial 999 and say my child's having an asthmatic attack than saying she's got allergic airways disease or something.
Yeah.
So labels are for, in the patient's interest, strong labels.
It's interesting, and especially if you go online, there's such an interest. There's sort of debates that happen on Twitter and things like that about the language that we use, and we sort of thought about the podcast and call it what we called it, and whether we refer to CFS or not, and we called it an ME and chronic illness podcast, because that was really important to us. But then I sometimes think in America CFS is used quite a bit, and then I think maybe we'd get more people finding us, or if we used CFS or ME CFS, because people might be searching for that more. But it's a very difficult sort of challenge to kind of find that balance, really. But to place ME as being an important, a very vital kind of like part of the language that we use.
One of the problems with CFS is that some of the definitions of it do not actually lead to ME. You can, a lot of patients who've crept into the trials, like the PACE trial, may not have had true ME. They may have had depression, and a bit of graded exercise might have helped them. And these certain definitions, which have mainly been to CFS, are not true ME. The beauty of NICE guidelines now is they've put four very clear symptoms to make the diagnosis of ME. No one should find it difficult, but they make post-exertional worsening the cardinal symptom, and that doesn't happen with depression and those other ones. And so a lot of the research and the labeling has been perverted by these faulty definitions, and including non-ME patients. So NICE guidelines are really good. And the long COVID ME has post-exertional worsening as well, and I advise those patients to call it long COVID ME rather than long COVID, because they then have the protection of NICE guidelines.
That's interesting. Yeah. So do you feel that maybe there will be a culture change amongst health professionals, and do you think that's possible, or it will happen following changes to the NICE guidelines? Because I remember when I did social work at university, going back, we did a module about evidence-based practice, and one of the sort of assignments I had to do was around culture change and how you manage culture change within big organizations. And I think the findings of that was that it's such a difficult thing to sort of like bring about culture change within organisation, especially something as vast as the NHS. Is that something that you kind of see for the future that's possible to, or is it just going to take a very long time for perceptions to change?
I'd love to see it, and we've got the tools and the opportunity to see it. Dr. Charles Shepherd is currently monitoring all the centres that claim to be ME specialist centres, and disappointingly, we're finding that many of them are not really changing their spots, and they're adapting to the abolition of graded exercise, but they're changing to a thing called energy management, which is actually not that different to the way it's practiced. It could be. The official NICE guidelines say we should now adopt pacing, which we've always said, but a lot of the leopards haven't actually changed their spots. And until medical education is taken over by people who believe in ME and understand it as a physical illness, there's still a lot to be done. But people can use NICE guidelines in their defense and educate their doctors with them.
Yeah. Are you in terms of sort of like diagnosis and treatment particularly, are you hopeful that we will see positive sort of progress in I find it personally really hard to keep track of the science and understand it and take it on board and things like that. So I kind of rely on other people that maybe disseminate that information. But do you think with Decode ME and things like that that we will potentially see some positive progress in the future, or does it feel quite bleak still?
There was a great flare-up of hope with rituximab from Norway, and the early results were dramatic. You heard the story about some immunologist who'd cured a patient of a lymphoma, and as she left, she said, "Thanks, you've also cured my ME." And they found it was rituximab, and yet the biggest trial they did after that came back negative, so that was a great disappointment. I sometimes say we'll find the cure for ME before we'll understand ME. There was a dramatic paper just on 3 adult patients with long COVID ME who'd been totally cured, miraculously cured by some monoclonal antibody. I'm not up on all the science, and I think there will be some breakthrough. And when we get it, the psychiatrists will have absolutely nowhere to go. And hopefully, I gave my 6 most severe cases immunoglobulin, which was in fashion at that time, following the first papers from Australia, and they all made full recoveries. And I still believe that immunoglobulin has a place. We don't quite know how. Unfortunately, the psychiatric bias and all that led to it falling into disrepute or falling into disuse. And it's very difficult to get anyone willing to prescribe it now. And NICE don't recommend it. But we've written a paper called Back to the Future, where we've reviewed the literature on immunoglobulin and found it's more favourable than the people have drawn conclusions from it. And I've got several patients in Europe whose doctors are giving immunoglobulin who are improving. So that we've already got something that is worth considering.
And what does that drug treat? What's it meant to do?
It's an immunomodulator. It's got antibodies. It's the kind of thing it would do is treat autoimmune diseases.
Right.
It is used in medicine for lots of other things like idiopathic thrombocytopenic purpura, which is an autoimmune disease. But it doesn't help everyone. It's not, otherwise it would have stuck. But sometimes a treatment can work in a subsection of patients, and it should be discarded when we don't have anything else to try.
Yeah. I tried aripiprazole, which had this amazing improvement spell for me for about 2-3 months, and I was like, "Oh, this is brilliant." And then I just crashed, and then I still take it sporadically, but it's one of them things that seems to sort of like and obviously that's aimed at sort of brain inflammation, isn't it? I guess.
Yeah.
And it does seem like we sort of just like we're just trying things and not there's just still this lacking this sort of like real evidence based sort of like research behind it. And but yeah, it's been it's good when we've got like doctors like yourself who've been involved in helping to push a positive narrative of ME. But one of the things that I did post on Twitter last week that I was going to be speaking to you, and if anybody had any questions, and so many of the questions that came back were very similar in regards to where do we go in the future in terms of like what are the are there sort of doctors that are coming through that are buying into a positive ME narrative, really? And because there's sort of cohorts of doctors that have been sort of carrying a flag for us in a sense. And do you see that there's sort of people coming through that are actually seeing ME and pushing forward a narrative, or is it a bit bleak in that sense as well?
I'm afraid I don't see it yet. When I was talking about NICE and how things should change, I'm saying that's the ammunition for change, but it hasn't happened yet.
Yeah, somebody said, "Can we clone Dr. Speight?" And seriously, what is the best way to educate medical professionals?
I think for postgrads, they have weekly meetings in hospitals, and there's nothing better than having one devoted to ME, having a doctor leading it, and having a patient telling their story. And once you've seen it, oh yes, I've seen a case like that. So often that people just have avoided seeing them. I mean, the whole paediatric departments that reject referrals from GPs or MECFS because they're saying we don't have a service. They always have this excuse: we haven't been trained. We haven't. I mean, the defence of the girl who died of starvation in the southwest was we haven't had a service commissioned for the treatment of severe ME. The excuses people make for not trying to help their patients. Yeah. Going back to the lack of curative treatment, firstly, that is one of the biggest problems for doctors. They hate a condition that they don't have a curative treatment for. And what they don't realize is, firstly, the patients can forgive them for that and they can understand that. And secondly, they'd be very grateful for the diagnosis. But then I've mentioned how treating migraine, improving migraine can help. If you nibble around the edges, there are quite a lot of areas you can help with. And there are drugs with symptomatic treatment, amitriptyline for the pains. I had a girl with severe sleep reversal and sleeping very little poor quality sleep. And she was operating at about 10% of functional capacity. And on 9 months, simply giving her melatonin, she improved to 80% over those 9 months, just because we'd improved the quality of her sleep. I should warn against a thing called sleep hygiene. And the way it can be done is as damaging as graded exercise. There was a girl who had severe sleep reversal and was sleeping 14 to 16 hours a day. She was admitted to a hospital, which should be nameless, for sleep hygiene for a month. And the parents thought this was a good idea because they were going to help her. And she used to sleep from 2 a.m. to 4 p.m. For that month, they woke her at 8 a.m., denied her any naps, and limited her to 8 hours a day. She had walked into hospital and she was carried out tube-fed a month later.
Wow.
And when the parents demurred with the expert who'd prescribed that, the expert said, I can assure you I have taken advice from the best sleep experts in the country for conditions other than ME. I mean, she didn't say that, but that was the catch. And I remember once a great truth that one of our nurses said. We had a very, very severe case admitted to our ward, actually under a court order. It wasn't my court order, the judge was just... And I had to give up. I never used to admit our severe cases to the ward. They were far better off at home. But this girl was coming into our ward, so I gave the nurses a talk about how they should handle severe ME and how they should tolerate the mother being present as the caretaker, doing this, doing that. And at the end of my talk, one of our best nurses said, so what you're really telling us is that everything we've been taught in our training as nurses is wrong for this condition. And I think that's the same. It's, you can't activate people and coax them and push them and make them get better.
No.
And you don't have to, you have to modify your nursing routines. You don't have to subject them to blanket baths daily against their will.
No. Yeah, and I think that's incredible when you hear stories of people who are, you know, in hospital at the minute, and they're sort of being pushed to have a bath daily, and like, I mean, many of us with ME don't have baths regularly just because of the impact on us and how exhausting it can be, and having to rest for so long afterwards. So the thought of being sort of forced to have a bath every day is just like it feels, well, it is abusive, isn't it? When you're sort of looking at ME as a condition and how it impacts us. So yeah.
Brings us to the challenge of the very, very severe case, and you've mentioned there are 2 or 3 cases going on at the moment which are very, very painful. And again, every medical team that sees a very severe case admitted to their ward it'll be the first time they've ever seen it, and they will make every beginner's mistake in the book. I made a beginner's mistake with my first severe one. I was worried I was missing something, and I sent her to Newcastle for a second opinion, and they kept her for 3 days and prog marched around the ward, did lumbar punctures. She didn't forgive me or her parents for 2 or 3 years. We'd promised her she'd just go there, get the opinion and come home, but they held on to her. She wrote a very dignified letter of reproach to the neurologist when she recovered.
Wow. Yeah. Yeah, it's heartbreaking, isn't it, when you hear these stories and you just want to, you just think, oh, just is it that people are, because it feels almost like there's a lack of compassion there somehow. Do you feel that it is to do with like a lack of compassion, or do you feel that people are so worried about doing the wrong thing that they do the wrong thing almost, or they're not willing to step out?
They're worried and they lack compassion. Yeah. Do you know the GMC has just revised their guidelines for doctors under good medical practice? And you won't believe it, but it's worth telling all your listeners. They've actually, for the first time, felt the need to tell doctors that they should be kind to their patients.
Wow.
Check out good medical practice. It's very good. And all the things, you should listen to patients, value them, informed consent, listen to their understanding of their own condition, negotiate with them about what you want to do. Don't do anything against informed consent. Work in partnership with patients.
Yeah. It seems like just such a simple thing, isn't it, to say be kind, and what does that mean? And once you start and unpack that, but that is the reality of it. So many doctors they're not able to kind of see beyond just their own sort of frame of reference, and it's frustrating. But one personal question that Elizabeth asked was, how do you find the strength to keep going personally?
Someone asked me that just recently over this severe case we've got, which I've not literally but virtually lost sleep over. And I told you about the Norwegian case. We've talked about the threat to families of safeguarding proceedings. And I'm not saying it's just because of my influence, but basically the good news is that of the 200 or so families who I've seen referred to child protection, who've had case conferences and been threatened and scared of losing their children, we have actually had the right results in about 98% of cases. So what a big defeat can spoil everything, with lots of victories. I actually get, it's the main reason I'm still working is that I get so much satisfaction, and there's such a need for this. As you said, I don't have that many colleagues who I can count on. About 10, 15 years ago, I had people in the south of England who Alan Franklin, Colin Stern at St Thomas's, Rashmin Tamni in the Midlands. There are large areas of the country I could leave to like-minded paediatricians, but they've all died or retired. And but it's very satisfying that if you could see the photos of the Norwegian boy reunited with his family and his dog, looking very, very happy. Every victory is very rewarding.
Yeah, yeah. And like, just for example, one person called Sarah Richardson said that Dr. Speight saved my daughter's life with the advice he gave, and he deserves a knighthood. So it's just,
Okay,
you know, there are those cases. Yeah, yeah. I think it's encouraging, isn't it, when you hear those sort of statements, and yeah, our hope is, and I suppose, yeah, a real hope is that there will be doctors coming through that will start and take, and particularly in pediatrics, because, you know, for children it's heartbreaking when you see the impact on them, and, you know, having been through that myself, and having a doctor like yourself who just showed compassion, which was night and day compared to the other side of things that I experienced, was, you know, you made a big impact on me, and I think you will have made an impact on so many children and who are now adults, kind of like, you know, who are either still living with ME or have kind of like had a level of recovery. So yeah, I would just say sort of thank you, and yeah, our hope is that things can progress and we'll see a more positive future. So
I could say one thing about living with ME, and I sometimes say semi-jokingly, it's easier to have ME severely than to have it moderately. And by that I mean the severe case has no choices. They wake up and that's it. But the moderate case, who's going to school 3 days a week, if that, and has the schools ticking off the non-attendance and looking disapproving and saying you could do better. I saw a succession of 12 families at a clinic I did in the southwest, and they were all of this sort. And lots of the cases I'm about to see in Ireland have the same questions: how do we do this, or am I doing things right? And if you're on the educational, if you're not so ill that you're off school, there are always decisions every day: what you're doing, what should you be doing, am I up to this? And at the end of the weekend, I looked at the 12 cases, all of whom had asked for advice in different ways. And I found that the advice I'd given in 11 out of 12 was that, in my opinion, they were trying to do too much. And that therefore they should back down. And my motto is take 2 steps backward so you can take 1 step forward. I remember a little boy who said to me, "But Dr. Speight, surely nothing's more important than your education." I said, wrong.
Wow.
Getting better from your ME is more important than your education. I've got kids who missed 3-4 years of school and made a comeback and went to Oxford, you know, got into university, and the value of full-time state education for someone who's a bit ill is exaggerated most of the time, because the schools can't tolerate the partial school loss. Parents have to homeschool just to get away from the pressure.
Yeah.
Do you know that the state does not recognise medically sanctioned absence? They add it to the school's absentee figures, and that affects their Ofsted rating, and they therefore have such pressure that they either pressurise them to school or force them to leave school to avoid affecting their statistics. And you know, Betty Dowsett and Jane Colby wrote a paper many years ago showing that ME is the largest cumulative cause of school loss in this country. And yet the system of dealing with it doesn't tolerate it. The pressure is enormous.
Yeah. And again, it feels, you know, it feels like things, haven't progressed, you know, in the sort of 30 years since I was sort of like a sort of 11-year-old lad, kind of living with, you know, sort of having to try and manage going to school or not, or whether, you know, home tuition and all that sort of stuff, and having to manage those things, and it feels frustrating that there's not a greater understanding, and that's partly the education system, isn't it? And it's frustrating, but yeah. Well, it's been really good to talk, and thank you so much for your time. It's been it's been enlightening, and it's been so good for me to kind of chat to you again after so long, and see the positives that have been done, and lament, I suppose, the frustrations and the way the system is feels like geared against those of us living with ME, and particularly sort of children where there's question marks and having to try and sort of support. But yeah, we can only hope that there'll be doctors that come through that want to sort of actually take a slightly different journey, and despite not being able to kind of like treat people, actually just being there and supporting is so important. And yeah, thanks again for all the work that you've done and continue to do. So it's been really good to talk. Thanks a lot.
Well, pleasure, and thanks all the people for the questions, and I hope some of them have helped, and at least make sense of the rather crazy situation. Okay, regards to your mum.
Yes, thanks a lot. I will pass that on. Thank you.
Right,
Bye.
go ahead.